and let me know that you can see it. All right, y'all able to see? I can't see. Are y'all messaging me? Yep, okay, thanks, hon. All right, common disorders of the female reproductive system, and go. All right, so I'll let you know what to take notes on and so forth. First thing we're gonna cover is breast cancer. Breast cancer, and just like any other cancer, is an abnormal growth of cells, and that's really kind of simplifying cancer, but that's all it is. It's when a part of your body's cellular production stops or doesn't get the signal to, hey, that's enough, stop growing. And it just makes more and more and more of the cell, and it becomes harmful and malignant. Malignant is a term that we're going to learn. Malignant means that it has become cancerous. So this is a term you do want to write down, and you want to make sure you know. All right. Benign is the opposite. It means there might be an abnormal growth, but it's not cancerous, and that can happen a lot. Breast cancer is actually a common concern for any woman. This is why we do breast cancer screenings. And if there's no history of a breast cancer in a woman's family, then we usually start at 40, and we'll have a mammogram. And if there is a history of breast cancer in a person's family, whatever age like say if it was a mother or the grandmother or so forth, they would go 10 years prior to that person's diagnosis. So if the mother was diagnosed at 40, then you would start having your breast exams at 30. Brian, turn the air down. Thank you. We really emphasize with our patients the importance of self-breast exams. And then that's something that, as an MA, that we can show and we can teach our patients. We can show them when they come in how to monitor their breast monthly and check themselves in between, because it's not a thing that should just be done once a year. It's a thing for women that should be a constant thing that you think, okay, this is how my breast feels, and get in the habit of knowing this is how my breast feels. It's lumpy and this and that. And the first time you do self-breast exam, you're always like, oh, there's lumps everywhere. Well, that's supposed to be that way. And we reassure our patient of that's normal. But what they're looking for is, hard knots, things that aren't usually there, or if the nipple becomes inverted, or if they start having discharge from the nipple, something like that. If the breast itself becomes swollen, swollen and red and inflamed, those would be signs. Or if there became swelling and discomfort in the lymph nodes around the area, that would be concern. So as women, we have an ongoing, responsibility to take care of ourselves, because I have fantastic news. With our technology that we have nowadays, if you go in and you get screened, and they find out, because every year going in every year at 40 and having your breast exam, and they say, okay, you have a cancerous mass, but it's brand new and we just caught it at stage 1. You go through your treatment and you have a 99.7% chance of completely being cured of that and never having complications at stage 1. At stage 2, it's not as good, but it's still in the high 80s, 90%. And then stage 3 drops drastically. And the reason is because as the stages progress, that means it is, we learn this term, metastasized. It means that it's spread, and we don't want that. We don't want that to spread to the surrounding areas, the surrounding lymph nodes, or the surrounding, other organs, because that decreases our chances greatly of survival. Treatment for breast cancer is usually chemotherapy, radiation, and surgery. And sometimes a mastectomy is necessary. And a mastectomy is a removal of the breast and all of the tissue surrounding the breast. This is an example of a typical look of what we would look at for a breast. We would see a lot of adipose or fatty tissue through here, and then we see the lectures, or the as far as for milk production. But this is what would be abnormal. So this is what it might show as in a patient. We can see it's not just a small little lump here, it's actually moved in and it's invaded other areas. So this right here is considered a stage 3 breast cancer. And this is an example of inflammatory, where the whole entire breast becomes inflamed and red. And this is an example, if you could see inside, and it's showing how, if it's not caught, how easily it can spread to lymph nodes. This is why we go in once a year after 40, and we have, or if we're at risk, and we have these reoccurrent mammograms to make sure that if anything is abnormal, we jump right on it. All right, the next thing we're going to talk about is cervical cancer. Cervical cancer, it means it's malignant. And the lowest part of our womb, or the uterus, we learned, is the cervix. And it can become invaded with abnormal cells. Now, the way that we can stay on top of that and make sure that we don't have an issue with cervical cancer is we go in, once we're sexually active, we go in once a year, twice, every other year. It's going to be depending on your doctor, what they suggest for you, family history, and how your tests come out. But I know now that the American Gynecology is saying that if you have 2 or 3 consecutive good pap smears in a row and no history, then you can go every 3 years. Me personally, I still like to go once a year, just to make sure. Now, somebody who is not, sexually, Brian, get me a drink. I can't stop yawning. Somebody who is not sexually active is not necessarily required or needed for pap smears. Now, that may depend. Some doctors may say otherwise, but it's usually something that's once the age of that they become sexually active is when they should start having a pap smear. The bad thing about cervical cancer is that sometimes there's no symptoms. Sometimes, if there are, it's really mild, like, spot bleeding or an irregular cycle. And the good news about this as well is that if caught early, it has a high success rate and good chance of survival. So that's why you're keeping up with your pap smears, your well-woman exams. We call them the WWE well-woman exams, and that's happens, it's scheduled up, and women should stay on top of that. And we work for a gynecologist, obstetrician. We make sure our patients follow up and keep their appointments. This picture here is showing a sectional view. If we were looking, and we can see through here from the vagina, here at the cervix, and if we was to look at it, this is why the doctor when you go in, everybody always wants to know, why are they using barbaric looking tools? Well, the speculum that they place or insert inside the vaginal canal actually is to open the vagina, and it has a light on it so that they're able to tilt it and open to see, because they want to visualize the cervix. And by looking at the cervix, they can see if there's anything abnormal growths, lesions, or anything like that. The next thing that they do is they swab it, and they get a little piece of skin tissue or cellular tissue from it. They send that to the lab, and then they just make sure. So it's a double way of checking and making sure nothing's abnormal. Brian, stop. All right. So the next term we're going to talk about is dysmenorrhea. Dysmenorrhea is painful periods, basically, or having pain, that's what dys is, during a period, during your menstrual cycle. There are two types of dysmenorrhea, primary and secondary. Primary is common. This recurs and it comes back. It's not due to a disease. It's just you're one of the unfortunate ones that have really bad menstrual cramping and so forth. The pain usually begins 1 or 2 days before, and then sometimes it can be felt all the way during the period, and then sometimes in the lower abdominal, back cramping and stuff like that. It can range from mild to severe. Some people even have nausea. Some people have fatigue and diarrhea and stuff with their dysmenorrhea. Now, secondary dysmenorrhea is different. Secondary means that it is second to an underlying cause, meaning that the woman has maybe endometriosis, adenomyosis, uterine fibroids, or something else. So something is causing her to not, to have an abnormal, painful period. Okay? Usually, this is, we see this a lot with STDs, and we see this a lot with people who don't go in regularly, have the screenings that they need and so forth like that. So staying on top of it, staying on top of your well-woman exams can also help with that as well. All right, next thing we're going to talk about is endometriosis. And endometriosis is a painful disorder. It's extremely painful, and it happens within the lining of the uterus, or the endometrium. And what happens is, basically, it's that we know that that's supposed to stay inside the uterus, right? Well, what ends up happening is that tissue begins to grow outside of the uterus. And sometimes it can actually grow around the uterus. It can invade into the ovaries, the bowel, the pelvis, everywhere. And what that is, it causes extreme pain. It causes abnormal periods. It causes heavy periods with some women. And sometimes surgery is needed. Sometimes, certain times, they can go in and they can do surgical procedures. Other times, they may need medication. Sometimes it may require a removal of the uterus because things are so overgrown or involved. And then I was talking about the signs. It's mainly pain. Pain during intercourse, pain during or after sex, pain during bowel movements, just overall pain. It's a very painful thing. And if left untreated, it can result in infertility. Like I said, the treatments would be, first, of course, maybe some birth control. If that didn't, then they might try hormone. In worst case scenario is, like I said, surgery. A term that you would want to know is called an adhesion. Adhesion is basically like we have nothing's just floating around inside of us. We have tissues that connect everything. But sometimes when these tissues become real thick, fibrous, or especially after a surgical procedure, they can become painful. And we some people will notice that area never feels quite the same. And adhesions are fibrous bands of scarring. All right. Now this is a term I said, it's fun to try to pronounce. It's called a salpingoophorectomy, and it's basically the name of a hysterectomy, and it's the operation to remove a woman's uterus. Okay, so you do need to know hysterectomy. Hysterectomy is the removal of the uterus. And this is talking more about uterine fibroids and reasons we might remove the uterus. Cancers, endometriosis, previous failed attempts at cervical cancer treatment, those kind of things. All right, the next thing we're going to move to is the ovarian cancer. So we know our ovaries are what produce and release our egg, or the ova, and if we have any type of cellular change there it can be 3 different types of cancers we can get with ovarian cancer. One of them is called epithelial, and I don't expect you to remember all of these. The other is germ cell, and the other one is stromal. But just basically, we can group them all up and just say ovarian cancer, okay? And ovarian cancer occurs, like I said, like other cancers, abnormal cell growth. Sometimes, if caught early, it can be treated, the ovary can be removed, the woman can still go on and be fertile and have a child and so forth. In severe cases, though, they might have to remove everything if the cancer's invaded areas. Risk factors for ovarian cancer, believe it or not, is a family history of breast cancer. And here's the next thing. If you take estrogen hormones for too long, it can increase your chances. Having fewer children or having them real late in life can increase your chances. The problem with ovarian cancer is it's usually a very, mild signs and symptoms. The symptoms develop over a long period of time, and it's vague. So fatigue, bowel habits, decreased appetite, nausea, middle pain, mild pain and discomfort, abdominal swelling, and pain during intercourse. These would be seen as all kinds of signs. But sometimes women have no signs, and there's no, way for them to know. So ovarian cancer is one of the ones that it's kind of hit or miss. If they catch it early, there's a good chance. If not caught earlier, it's, usually a lower chance of, remission and survival. And the treatment is based on the stage. So usually what I see now is if it's they usually remove it. They remove the ovary just to be safe. And if it's severe enough, they might even remove part of the surrounding area. And then if it's severe, this is where they might remove everything. Uterus, fallopian, ovary, the whole 9 yards. And chemo and radiation is also treatment and therapy. Now, an ovarian cyst is not cancerous, but it's painful. And it's when all a cyst is we know it's a little pocket of fluid. And that can form for, just like we have a pimple on our skin, a cyst can just form. When a follicle fails to rupture, or if it's not fertilized, that fluid can be form a cyst instead of being reabsorbed. And the good thing is most ovarian cysts go away on their own. Now, sometimes women have pain with this, and sometimes they'll have real hormonal change, weight gain, infertility, irregular periods, and we label this as polycystic ovary disease. All right, and this means that it's very complicated. It's not just a normal ovarian cyst that comes and goes and that kind of thing. All right, so this is giving you the different examples of types of hysterectomy. Okay, and I know this doesn't necessarily fit. Total, you would think they removed everything, but it's not. Total just means that they're taking the uterus. All right, a total hysterectomy with a salpine oophorectomy means that they're removing the uterus and fallopian tube and an ovary. And then it can either be one or it could be both. And then a radical is when they take everything, even part of the vagina. They take the tissue around everything because the cancer is advanced. And then there's two types of incisions that women usually will come across, and I talked about this the other day. The low transverse, or what we call the bikini cut, or a vertical. Now, if something's vertical, it's usually done in emergency situations now. This is a video that I'm going to post about ovarian cyst, and I'll place that in Teams. Like I said, for the most part, the symptoms could just be some pain, period abnormalities, irregular menstruation, or even some uterine cramping and so forth. But like I said, the good thing is they do usually go away and resolve on their own. If they don't, then a lot of times the doctors will say, hey, let's put you on some birth control, some hormones. And we found that women who are overweight do have a higher tendency to have ovarian cyst and the polycystic disease. So weight loss helps a lot with these. The last thing we're going to talk about today is pelvic inflammatory disease, or what we call PID, P-I-D. When we see a patient with PID, they are usually in extreme pain and discomfort. It's because it is caused by a sexually transmitted disease. Usually the infection has spread and just overtaken her entire the reproductive area, and the whole pelvis itself becomes inflamed due to this. It's very common with gonorrhea and chlamydia. If you don't have the STD treated and taken care of, pelvic inflammatory disease could lead to scarring, infertility, all kinds of things. I've even heard of resulting in death. So it's not something that it's to be taken lightly. We see with a lot of sex workers that they'll have STDs and they won't know it. They're not getting tested. They're not getting the proper treatment. And when they finally do come in, they come in barely able to move their feet or walk. And they kind of just shuffle. And it's actually termed the PID shuffle, or because the pain's so severe, they can't even lift their leg up to move their leg to walk. And this is giving you an example. So here, maybe you might have a healthy female reproductive system. Now, usually we get an STD and it might just be one, let's just say it starts one little, thing here, and if left untreated, it can grow. And it can cause abscesses. It can cause swelling, inflammation to where the entire area is infected. So this is where that pain comes from, and all of the swelling and the redness and the tenderness. And this is what I was talking about there, the symptoms. Treatment is going to be to treat the STD. We want to get rid of the STD because that's what's causing all of the inflammation and the pain. So we would use antibiotics, and sometimes they might even have steroids, anti-inflammatories, stuff like that to help reduce. And then the next step is prevention. How do we prevent this person from coming and having contact with this again? Condoms and teaching, education, informing the woman that this is how this happened. This is how we can prevent it. All right, and we're going to stop. We're not going to get into PMS today. Anybody have any questions? Nope. Well, then have a wonderful Friday. I'll post the video in Teams, and please make sure you get your homework and Survey Monkeys. Thank you. Make sure you hang up after the call as well, and then I'll post this to YouTube. Bye, guys.